Hola, Monsieur Onier. Donc, I'm going to change now for English for the formal presentations. So, good morning. We are about to start today's conference. This is our online Congress Pâncreas Week, an event dedicated to pancreatic oncology. Our aim for when we thought about organizing these presentations and this Congress was to bring some of the greatest authorities on this field to present their experience as the latest updates on the field. Before we would like to thank to the institutions and societies that are supporting this event, as the Brazilian Society of Oncology, the Brazilian College of HPB Surgery, and the hospital where we work, that is Marcelino Champagnat Hospital at Curitiba, Brazil. So our guests for this first presentations, first I would like to introduce you Dr. Marciano Anguinoni, who is an oncologic surgeon with a special interest on HPB and digestive oncology surgery. So thank you very much for your presence, Dr. Marciano. It's a pleasure to work with you, who's a partner in the same service.
Okay. Thank you, João. Good morning, everyone. Welcome to the third day of our Pâncreas Week, or Pâncreas Weekend. And I want to thank all the participants, remembering about 400 Brazilian surgeons and residents have applied for our event. And I want to thank today's debaters, my friends Andrea, my friend Paulo, together with Paulo in São Paulo, Belotto and Orlando Torres, and especially our guests, Professor Duckmack and Professor Savané. It's really a great honor, a great pleasure for us. Thank you very much, professors, for accepting our invitation. And I also appreciate the official support of Brazilian Society of Surgical Oncology and Brazilian College of HPB Surgery. I'm sure we have a great Saturday morning of discussion about pancreatic surgery. Thank you, João.
Thank you. And the second person who was invited is Professor Paulo Amaral. He's the president of our HPB College, and he performs HPB surgery in Salvador, Bahia. And it's also a pleasure to have him along with Orlando and Belotto on the same screen. Good morning, Professor Paulo Amaral. It's a huge pleasure to have you here today with us.
Good morning, everyone. Thank you very much, Marciano, Andrea, and Nicoluso for this invitation. It's an honor to participate of this event, and I hope it's very nice to see everyone.
And before presenting Professor Savané, we would like to, for people who are watching us, just to tell you that we're going to have two presentations. So the first one is going to be with him, with these two people to make the discussions, Marciano Anguinoni and Paulo Amaral. And just after that, Professor Duckmack is going to talk about laparoscopic pancreatic resections in the person who is going to be who's going to make the discussion is going to be Andrea Petruzzello, who's the one that I would like to introduce you now. Dr. Andrea Petruzzello is also an oncologic surgeon, HPB surgeon, former fellow at Montpellier, France, and also one of my partners at the same service of HPB in oncologic digestive surgery at Marcelino Champagnat. Good morning, Dr. Andrea. Sois bienvenue ici avec nous.
Merci. Thank you, Dr. João, Dr. Paulo Amaral, Marciano, all our friends. And again, we apologize for the little incident of yesterday, technical issue. But I think that today we'll have an even profuse discussion because we have the opportunity to talk about two very different approach with the same problem. So maybe this will be even more interesting, that it will be in a separate day. So thank you again for the precious time of Professor Sauvanet and Professor Docmac. I know very well that they are in a busy schedule all day long, all year long. So really, we want to thank you for your availability and your time. That we know there is not cheap for you. So let's begin, and we will talk a lot during the explanation.
So I would like to introduce you now, Professor Sauvanet and Professor Docmac, who is going to present just after him. So Professor Sauvanet is one of the most important authorities on the pancreatic oncology field in the world. At the time that I was in France in the 90s, he was the authority at Beaujon, and since there, he's still one of the most important persons in this field. Donc, Monsieur Sauvanet, merci énormément pour être là. C'est un vrai plaisir finalement vous connaître. Je suis resté 3 ans à Paris, 97 jusqu'à 2000, dans des hôpitaux de la PHP. Et j'avais toujours entendu de vous et parler de vous. Et voilà, finalement, j'ai le plaisir de vous avoir ici pour une conférence avec nous. Ravi vraiment, c'est un vrai plaisir. Et merci énormément pour votre temps, votre disponibilité avec nous. J'aimerais aussi présenter M. Docmac, aussi avec une gentillesse et profiter du moment pour les rendre un hommage pour hier, parce qu'il voulait partir à minuit à l'hôpital pour faire la présentation. Donc, c'est vraiment une chose incroyable, la disponibilité avec toutes les choses que vous avez à faire. Donc, M. Docmac, c'est aussi une des personnalités avec de plus d'expérience au monde en résection pancréatique partielle. Et pour nous, c'est un vrai plaisir de l'avoir aussi. Donc, je vous souhaite, vous deux, de belles présentations et merci énormément que les Brésiliens puissent avoir une telle présentation avec des gens avec une telle expérience comme vous. Monsieur Sauvanet, thank you very much for your time, and I hope you have a nice presentation. Thank you, sir.
Thank you very much, Dr. Nicoluzzi, for the very kind presentation. I'm very happy to make this talk. To prepare a talk is always a mean to learn some new things, to have clearer ideas. And the subject you chose is what are the main difficulties of pancreaticoduodenectomy and how to overcome these difficulties. It's a very large topic, but I would like to be concise. I hope I will succeed. To my opinion, these are the main difficulties of pancreaticoduodenectomy. First, during the preoperative evaluation, you have to use an accurate preoperative staging regarding PDAC. You have to avoid misdiagnosis, and you have to use the most appropriate management of jaundice. During the operation itself, you have to avoid arterial complication and to deal with some arterial resection. It's unusual but possible. You have to deal with some difficult venous resection and to deal with high-risk pancreatic remnant. And during the postoperative period, you have to deal with postoperative pancreatic fistula and hemorrhage. First, regarding preoperative staging of PDAC, one important thing is not to perform at first endoscopic examination. Why? Because this endoscopic examination, mainly ERCP and sometimes EUS guided biopsy, are able to induce some acute pancreatitis. I'm sorry, the letters are in yellow, but the prevalence of post-ERCP pancreatitis is around 8%. When the patient develops some acute pancreatitis, there is some inflammatory changes around the vessels. And in the setting of PDAC, if you have only the post-ERCP CT scan, you don't know if it's a tumor extension close to the vessel or inflammatory changes close to the vessel, so you don't know exactly what you treat, a borderline or even locally advanced carcinoma or a resectable carcinoma with inflammatory changes after ERCP. It's very important to communicate with the endoscopist about this point to avoid the risk of misclassification of PDAC. You have to use, as a first step, a dedicated abdominothoracic CT scan with a phase without contrast, then a late arterial phase after injection of contrast, and a portal venous phase to obtain the best opacification of vessels, the best visualization of the pancreas, the tumor, and the duct, and the best visualization of the liver. You have also to get some lung slices, because although it's not very common, some patients with an overall resectable PDAC have lung metastasis as presentation. And the radiologist should give you a standardized structure report to be sure that all the key points regarding the staging of PDAC have been evaluated. PDAC is evaluated for several years. And all the study regarding PDAC staging by CT have tried to identify criteria of non-resectability, of unresectability with a 100% specificity. You can look that the specificity of this criteria is very high, but as a counterpart of the high specificity, we have to accept a less than 100% sensitivity, and the sensitivity is around 80–85%. Why this sensitivity is imperfect? Not for evaluation of vascular leaf movement, because if you exclude the patient who had previous ERCP and the special setting of patient who had PDAC complicating IPMN, because some inflammatory changes are also possible in the setting of IPMN, the problem is not vascular evaluation, the problem is detection of liver peritoneal metastasis or distant lymph node metastasis, but mainly liver metastasis. You must be aware that to assess resectability of PDAC, previously untreated PDAC, a naive patient without chemo or radiation therapy, is not the same that to predict R0 resection with a margin more than 1 millimeter. Overall, CT overestimates the possibility of upfront R0 resection. The possibility of upfront R0 resection has less than, at the most, are 50%. And this is well demonstrated is with Korean series. The margin are frequently involved, and particularly the venous margin. The involvement of this margin can be predicted with a high specificity, but with a very low sensitivity. So this is an argument for neoadjuvant treatment, which is probably able to improve this margin and to decrease the rate of R1 resection. Regarding metastasis, to improve detection of liver metastasis, you have to be quick. Don't waste time between from the CT scan to the multidisciplinary tumor board or the operation, because the rest of unanticipated metastasis is minimal, provided the delay is less than 3 or 4 weeks. If the delay between CT and surgery or tumor board is more than this threshold, 3–4 weeks, the rate of unanticipated metastasis increase progressively. And unanticipated metastases are the main cause of non-therapeutic laparotomy. If you look at the experience of Baltimore, published 10 years ago, or the more recent experience of the Dutch pancreatic surgical group, you can see that metastases in particularly metastases, liver metastases are the most frequent cause of non-resectability. And if a metastasis is discovered at laparotomy, because a resection was planned, but actually it's not possible because laparotomy detects metastasis, it's a double punishment for the patient. First, the tumor is not resectable. And second, the patient will sustain the drawback of laparotomy, and the drawback of laparotomy in this setting are more important fatigue, a more important morbidity, a more important mortality, lower access to palliative chemo, longer delay to access to chemo, and overall, globally, a decreased survival, particularly if we compare with the situation of discovering liver metastasis during laparoscopy. So if you suspect liver metastasis or peritoneal metastasis, do not use open approach at first, perform a laparoscopy and will be beneficial for the patient even if this, the pancreatic tumor is not resectable. To improve the detection of liver mets, the main tool is MRI. MRI in this meta-analysis and also in some studies I will detail is a better tool with a higher accuracy, with a higher sensitivity and also a higher specificity for detection of liver metastasis. So this tool, MRI, reduces the risk of exploratory laparotomy, and we believe, and the French recommendation stated, the French guidelines stated that MRI should be performed in any patient who is otherwise a candidate for resection. If we look at this paper, it's the French prospective study in 118 patients with a normal liver on a dedicated MDCT performed for staging an adenocarcinoma, underwent subsequently an MRI with diffusion weight sequences, then a laparotomy or FNA for to biopsy any suspicious liver lesions. We detect 10% of, we detect a liver metastasis not visible at CT in 10% of the patient. We have some case of false positive, and it should be known. And the rate of exploratory laparotomy was only 3%, which is a very good score. And this usefulness of MRI is also suggested by the theory of Paoli Calmette Hospital in Marseille. The author analyzed their theory of planned resection for PDAC. And you can see the peritoneal liver metastasis and peritoneal metastasis were the main cause of non-resection, and that also MRI was in this multivariate analysis the most efficient tool to reduce the risk of exploratory laparotomy. Also, we can anticipate that MRI will be more and more accurate in the next future, because with some liver-specific contrast agents, such as Primovist or Multiens, the diffusion weight sequences and the overall MRI examination is more than sensitive than with regular contrast agents, even in the setting of very small liver metastasis, more than 10 millimeters. You can see then the sensitivity and the positive predictive value is very high with this contrast agent, including with small metastasis. It's also important to perform MRI because with this better selection of patients, excluding patients with very small liver metastasis, non-detectable by other means, you can anticipate that the risk of early hepatic recurrence postoperatively will be lower, so the disease-free survival will be better, and maybe even the overall survival after resection will be improved. To get a more, even more accurate selection of patients with PDAC, you should also look at the CA19-9. We learn from guidelines, and particularly the ASPO guidelines, that 500 unit of CA19-9 is a relevant threshold to predict non-resectability. But maybe we can use more appropriate threshold in patients without and with obstructive jaundice. You know that obstructive jaundice is able by itself to raise the CA19-9 level, and probably the most appropriate threshold are 150 when the patient is not jaundiced, and 220, 250 when the patient and an obstructive jaundice, and these thresholds can predict non-resectability with more than 60% positive predictive value. And with the CA19-9 is high, it's typically a good indication for staging laparoscopy to detect peritoneal carcinomatosis, to detect small liver metastasis, and some studies compared the yield of the staging laparoscopy according to the CA19-9 serum level, and you can see that the yield can reach 25% if the patient are at high risk of metastasis according to the CA19-9 level. What about PET-FDG? PET-FDG is not a good tool. This is, to my knowledge, the only randomized controlled trial comparing MDCT and PET-FDG. It is stated in this study that PET-FDG change the indication of the treatment of the pancreatic carcinoma in 43% of the patients. We cannot agree with the conclusion of this trial because the comparison with MDCT is fully biased, because there is no standardization of the technique of MDCT, no central review of MDCT, and to my opinion, the indication of PET-FDG are very selective, and it can be probably useful to assess the exact content of some abnormal distant lymph node, particularly station 16 lymph node. Lymph node metastasis at this level, para-aortic lymph node, is present in approximately 10 to 15% of candidates to resection. The patient who had lymph node metastasis on this site have no perspective of to be cured. Pancreaticoduodenectomy is useless in this setting, so it's important to try to characterize this lymph node. PET-FDG could be useful. Also, if you look at the paper dedicated on this point, the sensitivity for detection of N2 metastasis is very varying from 0% to 87%. So probably we need more studies to assess the exact yield of FDG PET. Second point, I think that every pancreatic surgeon should wonder whether in any patient, at least one time, at least once, is my patient harboring a surgical disease or a non-surgical disease. Why? Because if we establish preoperatively the diagnosis of surgical disease, PDAC, neuroendocrine tumor, IPMN, we can do some mistakes. We can make an inaccurate diagnosis, a misdiagnosis. About 8% of cases regarding preoperative diagnosis of PDAC, 5% of cases about preoperative diagnosis of neuroendocrine tumor and IPMN. So it's important to wonder whether if the patient are really a surgical disease or a non-surgical disease, such as regarding PDAC, autoimmune pancreatitis, some more rarely chronic pancreatitis. This is 2 examples. This is a patient with jaundice with pancreatic mass mimicking pancreatic adenocarcinoma. But you can see on this CT that the common bile duct harbor a long stenosis, and we can see the common bile duct. It's the penetrated sign described by radiologists. You can see on this MRI a double duct stenosis with mild or moderate MPD dilatation. This is suggestive of autoimmune pancreatitis. And in this case, EUS-FNA is indicated to avoid unnecessary resection. This patient should be treated with steroids and not surgery. And this is 3 cases of false neuroendocrine tumor. You can see that at CT or even at MRI, the appearance of this lesion mimic neuroendocrine tumor, but actually it's only solid serous cystadenoma, fully benign lesions, not to operate, and EUS could be very helpful by detecting microcyst and while also helping to perform FNA. It's possible to biopsy this serous cystadenoma and to have a certain diagnosis with EUS. Jaundice, what are the indications for biliary stenting before pancreatic duodenectomy? This indication must be selective. First, it could avoid the very rare cases of post-ERCP necrotizing pancreatitis contraindicating resection. This setting is approximately 1% of cases. Also, if you use selective indication, you will avoid to some patients the drawbacks of preoperative biliary drainage, particularly in patients who have no advantage to be drained before the operation. You know very well this randomized control trial from Netherlands, which demonstrated that routine preoperative biliary drainage in patients with less than 250 micromoles of bilirubin experienced more morbidity than patients who had upfront surgery without drainage. And particularly, the patient who had preoperative biliary drainage could develop pancreatitis, cholangitis due to early occlusion of stents. And furthermore, they also experienced a higher morbidity of surgery because due to bile contamination, they developed more frequently septic complications, particularly wound infection. Conversely, to perform a pancreatic duodenectomy in patients with severe jaundice exposed to a higher morbidity, higher rate of severe complication, and even higher mortality, these are 6 studies evaluating the optimal threshold to perform preoperative biliary drainage. More of this series identified the 250 micromoles as the appropriate threshold to indicate drainage. But in this series from Verona, you can see that in patients who had more than 130 micromoles per liter of bilirubin, the morbidity was increased, the risk of postoperative bleeding was increased, the risk of renal failure was increased, the risk of reoperation was increased. So probably the optimal threshold to indicate drainage is between 130 and 250. The problem of this study is that they are all retrospective and they are not randomized, so we have no other results on an intent to treat analysis. But remember that between 130 and 250, probably you have to perform preoperative biliary drainage. But which type of drainage, which approach? Percutaneous, endoscopic with metallic stent, endoscopic with plastic stent. This is a meta-analysis trying to identify the best procedure, and this meta-analysis, this systematic review, failed to identify the best technique. Regarding percutaneous approach, you know that it is very popular, at least in Asian countries, but be aware of the long-term consequences of this approach, because one collective series, multicentric series, identified an increased risk of peritoneal recurrence after percutaneous drainage versus endoscopic drainage and no biliary drainage. There were more than 100 patients included in this collective series. And maybe the risk is the same that observed with percutaneous drainage in patients with clad skin tumor, because in clad skin tumor also there is a risk of tumor seeding on the percutaneous, along the percutaneous drains, and contamination of the peritoneal cavity. The risk of failure of stent, preoperative stent, is around 4%. What to do when it's not possible to insert a stent through the papilla after sphincterotomy? The alternative, the recent alternative, is to perform an endoscopic choledochondroidenostomy with electrocautery and some lumen opposing stent. It's appropriate to perform preoperative biliary drainage because it's simple. The risk of complication is not excessive. There is theoretically no risk of acute pancreatitis, but probably in the midterm, in the long term, it's not a good solution because there is a risk of indicated risk of cholangitis, probably due to food infection into the stent. You have to prefer metallic stent. It's clearly demonstrated. If you use plastic stent, although they are cheaper than metallic stent, the risk of cholangitis, early obstruction is increased. Furthermore, in this collective series from Netherlands, you can see that the use of plastic stent was associated after PD with a higher risk of postoperative pancreatic fistula, maybe than observed with self-expandable metallic stent, probably because these metallic stents are able to induce some obstructive pancreatitis. They can occlude at least partially the main pancreatic duct, and maybe these metallic stents can favor the healing of the pancreas during pancreatic choledochondroidenectomy. Covered and uncovered metallic stents are equivalent, no difference at all. And the main question for surgeon is what to do when the serum bilirubin level is close to the threshold indicating drainage. There is two possibilities. Either you go quickly to surgery, and in this series you can note that the mean serum bilirubin level in more than 100 patients was not modified with a mean delay of 4 days. It can go up in some patients, go down in some patients, but overall, no significant increase. Or you can use this table, which is, in my knowledge, the only paper studying the natural history of obstructive jaundice. As an example, if the patient at first presentation is 100 micromole of serum bilirubin, you have to wait 9 days to get 200 micromole rate of bilirubin. So it can be stable, can be useful to indicate or not preoperative biliary stenting in patients who are candidates for upfront surgery. Now, intraoperative complications, arterial complication, difficult venous resection, and management of high-risk pancreatic remnant. The most terrific complication of pancreatic choledochondroidenectomy are ischemic complications, and these complications should be detected preoperatively, should be predicted by the detection of risky situations. Risky situations are the the setting who favor the development of very large and useful collaterals along the pancreatic head with a dilated gastroduodenal artery, dilated pancreatico-duodenal arcades. This setting are celiac axis compression by median-arcuate ligament, 10% of the general population, and stenosis, usually arteriosclerotic, of the superior mesenteric artery, which is rarer, about 1% of the general population. For the young surgeon, I will describe what happens when you perform a pancreatico-duodenectomy in a patient who had a significant stenosis of the celiac axis. You can evoke this possibility during intraoperatively during the gastroduodenal arterial clamping test. If you clamp the gastroduodenal artery and when there is no more arterial flow in the hepatic artery, this suggests that celiac axis is compressed at this level. And in patients who had no extrinsic lesions, if you perform a pancreatico-duodenectomy, you divide all the arterial supply from the pancreatic head and the duodenum. So the blood supply of the arterial tree is maintained unless there is an arteriosclerotic stenosis on the celiac axis, or if there is a trauma of the hepatic artery, and trauma of the hepatic artery can be observed during difficult dissection. If the patient has a chronic pancreatitis, the dissection of the hepatic artery can be difficult, and if the patient has borderline PDAC with some adhesions to the hepatic artery, there is also a risk of trauma resulting in a biliary ischemia. So it's important to detect this condition and to detect also the right condition exposing to arterial complication. It's the presence of a right hepatic artery arising from the SMA, and the prevalence is 15% in the general population. When you have ischemia in the territory of the celiac axis, you can develop gastric ischemia, or more frequently liver, but mainly intrahepatic biliary ischemia with a risk of liver abscess, recurrent cholangitis, and recurrent sepsis. And actually, the mortality of this ischemic complication is very high, up to 85% in our experience. So it's important to detect this predisposing condition, and the best tool to detect this predisposing condition is the preoperative CT scan. You should look routinely at the celiac axis, superior mesenteric artery, to detect median-arcuate ligament, arteriosclerotic lesions, or on the celiac axis or on the SMA, and to use the most adequate preventive measure. And the most adequate preventive measure is division of the median-arcuate ligament during pancreatico-duodenectomy, or for patients who had atherosclerotic stenosis, to ask for your best friend who is the interventional radiologist to dilate and then to stent the celiac axis of the superior mesenteric artery. For the special setting of right hepatic artery arising from the SMA, if the patient had a benign disease, you have to preserve this artery. In case of malignancy, you should preserve this tumor provided the R0 resection seems feasible. It's usually the case for non-pancreatic, for lesions different from PDAC. For PDAC, it is important to analyze very precisely the CT scan. If the tumor is very far from the right hepatic artery, you can try to preserve it. But in some cases, it's necessary to resect. So you have to choose between right resection, hepatic artery resection, then reconstruction, or more simpler technique, which consists of preoperative occlusion with coil, then pancreaticoduodenectomy with en bloc resection of this accessory artery. And this is an example of a patient who had borderline tumor treated by chemoradiation with a very slight decrease of the tumor size. The right hepatic artery is close to the tumor, and the radiologist catheterized this accessory right hepatic artery, occluded it, and 10 minutes after occlusion, we saw through the arterial pathways around the hilar region area, we saw collaterals with allowing a good supply of the right liver from the left liver perfused by the celiac axis. And in this patient, the pancreaticoduodenectomy with resection of the right hepatic artery was feasible without any complication. So another message, before any pancreaticoduodenectomy, check routinely vascular anatomy on CT, ask for vascular reconstruction, look several times at this preoperative CT to be sure that there is no lesion predisposing to arterial complication. Since I speak about artery, what to do in some patients who have PDAC with arterial abutment or encasement. Is PDAC with arterial resection feasible? Is pancreaticoduodenectomy for PDAC with arterial resection feasible? Resection of celiac axis? No, I'm sure. Superior mesenteric? No. I will give you some results of the literature. And for hepatic artery, it's possible to perform a resection of the hepatic artery provided this extension is limited to the origin of the gastroduodenal artery on the hepatic artery. End-to-end anastomosis can be feasible, but it's very rare, and usually when this terminal anastomosis is not feasible, you have to reimplant the hepatic artery on the transposed splenic artery. So the splenic artery is divided here. You mobilize the celiac trunk, and the proximal part of the hepatic artery, you perform an anastomosis at this level to avoid liver ischemia and the long-term consequences of biliary ischemia in the postoperative period. I told you that arterial resection is not only feasible in case of resection of a hepatic artery. If we compare the result of these two reviews of the literature, the mortality associated with resection of the SMA is only 23%, is not only, is 23%, 1/4 of the patient. I think it's excessive. Conversely, a resection of a pancreatic head combined with resection of the hepatic artery is associated with 7% rate of mortality. That is more convenient. The debate is not so simple because to avoid early complications and particularly arterial rupture due to pancreatic fistula in case of hepatic arterial reconstruction, some surgeons promote total pancreatectomy, completion pancreatectomy, routinely associated with arterial resection. So probably the postoperative period will be more secure because there is no more risk of pancreatic fistula and subsequent arterial rupture on the at the anastomotic level. Conversely, the quality of life of the patient is significantly decreased. So I think that this debate is not so simple. Regarding SMA, no arterial resection, but it's possible to use another technique that is skeletonization after neoadjuvant treatment, also called divestment by some author. And this has been well demonstrated by some very experienced pancreatic surgeons dealing with a lot of borderline or locally advanced PDAC, the group of Heidelberg. And the group of Heidelberg published recently a series of pancreatectomy for locally advanced pancreatic carcinoma, and some of them have had arterial resection, 195, and some other have skeletonization of the artery, pancreatic periarterial divestments, such observed on this photo. You can see that the superior mesenteric artery is completely skeletonized. What we observed that the mortality of resection was very high in the early experience, but reduced to 7% and their more recent experience. Conversely, the mortality of periarterial divestment was very low, only 2.3% in their most recent experience. And you can see that the long-term survival is no different. So periarterial divestment is simpler and more secure and offer the same possibility of cure than arterial resection. So I think there is no more a place for resection of the superior mesenteric artery. For venous resection, what is the best technique? The best technique is artery first approach. The principle is to divide important structure only once you are certain that a radical resection is possible. So you have to dissect all the artery to all the relevant arteries and mobilize completely the specimen and to pedicularize the specimen to the area of venous involvement before to perform the resection. There is two ways for this artery first approach. The classical way is a right posterior approach. You make a Kocher maneuver and you isolate the origin of the superior mesenteric artery. You skeletonize the superior mesenteric artery. So it's a posterior approach, which can be, however, difficult in obese patient or when the tumor, the pancreatic head is huge. And the other possibility is to use an inferior approach, inferior and anterior in the mesenteric root. It's appropriate for tumor invading the distal SMA, particularly on the first jejunal collateral, a tumor of the uncinate process. It can be also a little bit complicated because to have good exposure or off collaterals, you have also to dissect the vein. What are the main principles of venous resection? You have to dissect extensively all the vein using artery first approach, a meticulous lymphostasis, particularly in the mesenteric root. You have to mobilize the mesenteric root when you think that you will have to resect more than 15 millimeters of vein. You can avoid twisting the vein by inking the anterior edge, clamping with automatic ally clamps, using sites located far from the tumor. You have to use a 3 to 5 millimeters margin from tumor adherence. And the priority is to restore a perfect bowel and colonic drainage. The drainage of splenic vein is important, but it can be performed, achieved in the second time after you are sure that the restoration of the bowel flow, venous bowel flow, is correct. So this is one example of skeletonization of a tumor, pediculization of the tumor on the only area on tumor adherence. This is a second example. And you can see that the SMA is completely dissected, as well the hepatic artery the tumor is only attached to the zone, the area of tumor adherence. What are the techniques appropriate for venous reconstruction? For lateral resection, you can perform a transverse suture, but usually a patch is needed, and the peritoneal patch is a very easy technique. Toncular resection in approximately half of cases, and venous graft is very exceptional because if you mobilize the mesenteric root, usually you can resect up to 5 centimeters of vein. So it's very exceptional to use either jugular graft or left renal vein graft. We are very fond of peritoneal patch because it's very easy available. You can provide it on an urgent basis. It's costless. However, you have to be aware of there is one fatty face and one face consistent with contact with the venous lumen. So maybe the most sure type of patch is a patch harvested of the falciform ligament because there is no fat. It can be sometimes very difficult to handle, but if you use stitches for presentation, it can be very easy to use. It's very appropriate for lateral reconstruction. The only difference with end-to-end anastomosis is that the clamping time is longer. If you have a 3 centimeter defect of lateral defect of vein to reconstruct, since it's useful to make some interrupted stitches on the angle to avoid stenosis, the clamping time is probably longer than a classical end-to-end anastomosis. This is one example, a long lateral involvement of a superior mesenteric vein. All is dissected, relevant veins are clamped. This is the division, the beginning of the division of the superior mesenteric vein. Then you can see that the defect is very long. And inside the defect, you can see both the first jejunal vein and the superior mesenteric vein. You use a long patch harvested on the falciform ligament. You suture the patch inside the superior mesenteric vein lumen to be sure that you don't occlude one osteum and one other osteum. And after enclamping, you will obtain good permeability with no stenosis of the superior mesenteric vein, with no interruption of collaterals. This is a colonic vein, which is also patent, the first jejunal vein in patent. So that's an advantage also of lateral repair, if possible, is that you preserve collaterals that can be useful in the postoperative period if you have some limited thrombosis. Limited thrombosis is well tolerated when collaterals are present than where they are absent. You can also perform tubular reconstruction using peritoneal patch. It's much more difficult. Safi Dokmak published 7 years ago the first series of use of peritoneal patch in HPV surgery. This is more recent series with more than 100 patients. Mainly, the main indication were pancreatectomy with resection of the mesenteric portal vein. Half of the patch were harvested on the falciform ligament, and they were mainly used for lateral reconstruction. The early results were very good. We did not observe any necrosis or bleeding on the area of graft or graft suture. And regarding patency, the long-term patency was very high, 92%. And the majority of cases of thrombosis were observed in 2 settings, tubular reconstruction. I think it probably should be considered as a contraindication. And distal pancreatectomy, probably because in the setting of distal pancreatectomy, there is a risk of pancreatic fistula with a collection very close to the reconstructed vein, and probably some inflammatory changes or compression phenomena which favor the occurrence of thrombosis. What are the results of pancreatectomy with upfront venous resection? A slightly higher mortality, a slightly lower survival. It's well demonstrated in this big series, multicentric series, one from France and one from USA. There is a twofold increase of the mortality. The overall morbidity is the same as the mortality is increased. And also in this very recent series from Heidelberg, huge series, almost 700 cases of venous resection, 1/3 of their experience of pancreatectomy, few use of neoadjuvant treatment, a majority of pancreaticoduodenectomy, but you can see also a very important effective sample of total pancreatectomy. The mortality is overall 6%, but is important comparatively to pancreatectomy without venous resection. Very few pancreatic fistula, but there is half of patients with total pancreatectomy. The rate of delayed gastric emptying is significant, and you can see that the rate of portal thrombosis is overall 7%, but 21% after reconstruction using a graft, and probably because they use preferentially prosthetic graft. And one of the conclusions of this paper is that the indication of type 4 resection should be exceptional. The survival is not better after neoadjuvant treatment than after upfront resection, but it is not a prospective study. And also the neoadjuvant treatment was very heterogeneous because it was not always done in Heidelberg. What are the actual long-term results? There is more R1 resection after venous resection. The venous, although the venous involvement is not constant, observed only in 2/3 of the cases. The rate of recurrence is important, and 3/4 of recurrence are metastatic, and the survival is decreased, as appropriately described by Jean-Robert Del Perro in the survey of the French Association of Surgery. So it's needed to change this approach, and I think that today the appropriate approach is to perform first a neoadjuvant treatment for this kind of borderline resectable tumor. And in this very recent meta-analysis, you can see that the survival on an intent to treat analysis is clearly improved when you use a neoadjuvant treatment than when you perform an upfront surgery. We are still waiting for subsequent trials, because if we look at this result, we can anticipate that in the next future, neoadjuvant treatment will be the rule, probably also for resectable pancreatic adenocarcinoma. High-risk pancreatic remnant. It's easy to identify high-risk pancreatic remnant preoperatively with the appropriate scores using the gland texture, the underlying pathology, the main pancreatic duct diameter, the BMI, the gender, because male are more exposed to pancreatic fistula than female. Some of these scores are rather complex, including a French score we developed with Jean-Robert Del Perro 1 year ago. But probably it's also important to include the positive effect of radiation therapy. The patient who receive preoperative radiation therapy are less exposed to postoperative pancreatic fistula than patients who had only chemotherapy. What is the best procedure for reconstruction? Regarding the only rate of POPF, the best technique is pancreaticogastrostomy. That's demonstrated by some randomized controlled trial and some meta-analysis. However, pancreaticogastrostomy is also associated with higher risk of grade BC post-pancreatectomy hemorrhage. So you have to choose between one complication and one other complication. The last point is that in case of grade B POPF, it's probably more difficult to continue oral feeding when the patient has pancreaticogastrostomy than when the patient has pancreaticojejunostomy. And we done a lot of pancreaticogastrostomy some years ago, and from time to time we have to stop the oral feeding because the content of the drainage was food. So we progressively moved with pancreaticojejunostomy because we think that conservative management of pancreatic fistula is simpler with pancreaticojejunostomy than with pancreaticogastrostomy. Which technique is better for pancreaticojejunostomy? We don't know. Duct to mucosa or invagination, some randomized controlled trial, but no clear conclusion in this meta-analysis. It's the same regarding Bloomgard technique. Bloomgard technique was supposed to be the best technique for reconstruction using pancreaticojejunostomy, but recently, two randomized controlled trials were published, and there was no difference between Bloomgard technique and conventional pancreaticojejunostomy. What to do in high-risk patients? Pancreaticojejunostomy or pancreaticogastrostomy? A part of the answer in this randomized controlled trial from Verona, only 36 patients in each arm. However, there was a difference with a higher rate of severe complication after pancreaticogastrostomy, and particularly a higher risk of postoperative hemorrhage, which is consistent with the findings observed in the world literature. So pancreaticojejunostomy should be preferred, but what is important also in this paper is that the author used externalized stent with intubation of the main pancreatic duct, and external stent seems the most effective technique to reduce the risk of pancreatic fistula in patients with a soft pancreatic remnant, as demonstrated in the meta-analysis of 3 randomized controlled trials. Conversely, internal stent seem to be not as effective than external stent. Also, in these large cohorts from US, there were an improvement of the result with a decreased risk of pancreatic fistula significant when the patient had a pancreaticojejunostomy with an external pancreatic stent intubating the main pancreatic duct. So a high-risk patient should have 2 drains, one drain and in the main pancreatic duct and one drain around the anastomosis. And this drain seems able to decrease, this transanastomotic stent, external, seems able to decrease the risk of grade C POPF. However, you should be aware when you use an external pancreatic stent, you have to avoid, to prevent actively the risk of malfunction of the stent, which can be due to displacement, obstruction, kinking of the drain. So it's there is a learning curve to perform to manage efficiently the drain in the postoperative period. It's important that the drain should be perfectly functional and patent. This paper from Verona demonstrated that when there is some malfunction of the drain, the results in terms of POPF have worse than clearly worse than when the drain is patent and fully effective. Manage some excess in length in the jejunal limb, try to fix one time, another time, maybe a third time the drain, and to use periodic rinsing to be sure there is no obstruction of the drain. My last slide is about postoperative management. A very important tool for postoperative management is CT scan. 10 years ago, we made a paper, 13 years ago, we make a paper describing the usefulness of routine CT. Routine CT that we performed at the end of the third week in 100% of our patients with a high-risk pancreatic remnant. Some of our surgeons were not in agreement with us, but we included also patients with low-risk pancreatic remnants. I think that the liberal use of CT allows to pancreatic surgeon to learn what is the semiology, the radiologic semiology of pancreatic duodenectomy in the postoperative period. This is a seromite. It is not a collection due to fistula. This is a fistula with some air bubbles and collection in the lesser sac. This is a fistula which is perfectly drained by the open drainage. This is a collection which should be drained. This is a disruption of the anastomosis with a collection in the lesser sac. It's also important that the CT scan should be performed with an arterial phase in the postoperative period to examine the artery to be sure that there is no pseudoaneurysm of the gastroduodenal artery stump or pseudoaneurysm on the collaterals of the ESMA. In some patients, the semiology, the radiologic sign is very less marked. This is a stump of the gastroduodenal artery slightly increasing in size. This CT was performed after the third episode of sentinel bleeding, and this one after a second episode of sentinel bleeding, and we performed an arteriography. There was a false aneurysm, and this is some cases of irregularities on the hepatic artery. This is a pseudoaneurysm also, but you can see that the hepatic artery or the splenic artery has no very straight contours, and indeed these arteries are clearly fragile and able to rupture and are, to our opinion, indication for stenting. We got this year the demonstration that postoperative CT is useful and necessary, and there is some warning sign. I think you all read this very important paper from the Dutch Pancreatic Cancer Group, who described the standardized management in the postoperative period, and one of the initial steps of this management, and indication for CT scan, to detect fistula collection. For best postoperative management after PD, there are also very recent papers to know. I think that you have to remember that to avoid a wrong decision, it is important to solicit to have the advice of the whole team and not to ask to the main operator of pancreatic duodenectomy, which is probably the worst decision maker. That you have to promote as often as possible a surgical treatment. And when you have to reoperate, you should avoid to choose the wrong procedure, and particularly completion pancreatectomy. And I think that it's important to standardize the management, at least into your group for the benefit of the patient. This is a paper from France who analyzed the cause of death after pancreatic duodenectomy, and they demonstrated that 40% of avoidable deaths were related to a wrong management in the postoperative period, wrong decision or loss of time and so on. This is an important paper from the Netherlands, who analyzed what were the best management of grade B and C POPF complicated by sepsis. It was not a randomized control trial because this was not possible, but they performed a retrospective analysis using matching by proportional score analysis, and they demonstrated that catheter drainage was associated with the best evolution, post-operative evolution, the best prognosis with less death, less organ failure, and also best long-term result, probably because some of the patients who had real laparotomy and did not sustain the good procedure, and the good procedure was determined in this other paper from the same group of pancreatic surgical group of Netherlands. They analyzed the post-operative evolution after reoperation for complication of pancreatic adenectomy. And they identified multiple organ failure at the time of relaparotomy, and also perform a completion laparotomy as independent adverse prognostic factor. So we should remember that to perform completion pancreatectomy is excessive in the majority of patients. And one of the main value of the post trial from Netherlands, and that they propose a rational and systematic algorithm to reduce mortality, and this algorithm is effective because the main score, the main endpoint they choose, a composite score, was reduced in the intervention arm using the new protocol of post-operative management, but also the 90 days mortality was significantly reduced, 3% instead of 5% with the management of pre-existing in each of the 17 centers who participate to this trial. And also they demonstrated that the failure to rescue risk was reduced with this new algorithm of management. Lastly, bleeding. Bleeding is often sudden but often preceded by a sentinel bleeding. So we have to remember 5 things, 5 elements. There is never a small bleeding after pancreatic adenectomy. Because for every patient, the situation can be very quickly very dangerous. Second, a routine CT scan with arterial phase is emergently needed. Third, at the slightest doubt, an arteriography with or without embolization should be performed. 4, transfer the patient to ICU. And 5, I think it's important, you have to detect the residual arterial lesions, because there is a risk of rebleeding, and this residual arterial lesion should be treated to limit the risk of rebleeding. This is our experience. We published with the radiologist 5 years ago, 70 patients, almost 70 patients who had a third arteriography. Some were completely cured by embolization, some rebled. Some of those who rebled were emergently reoperated. Some had arteriography with abstention and reoperation, failure and reoperation, or success. And some of these patients who had success had a third arteriography. So with this combination of 1, 2, and even 3 in some patients arteriography, the endovascular treatment was effective in 3/4 of the patient, but 1/4 of the patient had to be reoperated. So we analyzed some of this failure, and we identified that some of the patients would probably have benefit for routine screening of arterial residual lesions, and there's a patient who had a pseudoaneurysm treated by cold embolization, 1 session, who experienced bleeding some days later. He had a second embolization without reevaluation. Then he rebled, but the pseudoaneurysm had completely growth, and this patient ultimately had to be reoperated and died. We do believe that this patient should have benefit from routine reevaluation after the first or the second embolization, and although the hepatic artery is very dilated, he will have benefit from a large covered stent inserted into the hepatic artery. And this is one recent case of patient who had pancreaticoduodenectomy with resection of the hepatic artery. He developed fistula, pseudoaneurysm, and the anastomosis, treated by covered stent. At the end of covered stent, there was a residual pseudoaneurysm, and this patient had another session of interventional radiology before occurrence of a second onset of hemorrhage. Overall, to obtain the hemostasis by interventional radiology is a little bit more difficult than to obtain it by laparotomy. But regarding the mortality, interventional radiology is a better tool because it's a minimally invasive and minimally invasive approach, even in the postoperative period of pancreaticoduodenectomy, as demonstrated by the papers from Netherlands regarding POBF, is an important way to reduce the mortality. So this is my conclusion. Don't begin workup by endoscopic procedures. It's you have to give some instruction to the gastroenterologist. A recent dedicated CT scan is a main tool with arterial phase to detect a risky anatomic situation exposing to ischemic complication, and completed by liver MRI for PDAC. PDAC amenable to resection, PDAC amenable to surgery. Don't forget the risk of misdiagnosis leading to an unnecessary resection. Use selective indication for preoperative biliary drainage and prefer endoscopic approach and metallic stents. Arterial resection during pancreaticoduodenectomy, it's always to perform after neoadjuvant treatment, and the only hepatic artery is amenable to resection. And the problem is, should we perform at the same time total pancreatectomy for SMNO resection, but arterial skeletonization is preferable. Venous resection always after neoadjuvant treatment. For after lateral resection, direct closure or peritoneal patch, and avoid graft replacement, which exposed to higher risk of thrombosis. For risky pancreatic remnant, pancreaticogyginostomy with externalized pancreatic stent, and active prevention of stent malfunction. And for management of complication, try to use a more standardized approach with a standardized and I think liberal is preferable use of CT scan. Interventional radiology should be preferred whenever possible. In the case of reoperation, try to avoid completion pancreatectomy. Thank you very much for your attention. I'm very sorry that I spoke a long time.
Thank you very much indeed, Professor. It was an outstanding performance, and I think that all details and all aspects of pancreatic surgery, they were responded by your presentation. Thank you very much. It was far more than we had expected. Thank you very much. Sir, would you mind just stopping your sharing so that yes. Yeah, because then we're gonna be on a bigger screen, and then we're gonna have the discussion of your presentation. Yeah, thank you.
Is it okay?
Yeah, it's better like this. So now I'm gonna open for the discussion with Dr. Marciano Anguinoni and Professor Paulo Amaral. Thank you very much.
Okay, thank you, João. Professor, it was a really outstanding presentation, really outstanding, full of information, presenting many of the dilemmas and controversial points, such as preoperative drainage, staging laparoscopy, vascular resection, and I think the professor exhausted all of the comments I had prepared. And I would have other comments, but I think we won't have much time. So just little points. Professor, first, about vascular resection, vascular reconstruction. What about splenic vein? Are you concerned about the risk of sinistral portal hypertension? What's your approach when you decide to reconstruct the splenic vein? And do you clamp the SMA when reconstructing, when performing complex reconstruction of the SMV? And is there a time limit to clamp the SMA? Sorry, time limit to clamp the SMA? What do you think about, Professor? Thank you.
Thank you for your question. I have 3 slides for splenic vein, but I keep it on side. Splenic vein, it is not necessary to make a reimplantation because routinely, because in a significant part of the patient, the splenic vein is anastomosed anatomically with inferior mesenteric vein, or also it can be also anastomosed anatomically with the left gastric vein. So if you don't suppress the confluence of either the inferior mesenteric vein or the left gastric vein with the splenic vein during resection, you have not to make any reimplantation because this collaterality can be efficient. The flow become inverted in the inferior mesenteric vein, also in the left gastric vein, and the stomach and the spleen will be perfect. From time to time, you resect this confluence, and the stomach or ever the spleen become congestive. So you have to look if it's not possible to reimplant, to reanastomose the splenic vein to the inferior mesenteric vein or to the left gastric vein. I think that anastomosis with the left gastric vein is rather difficult because the wall of the left gastric vein is very thin, and usually you are not very enough to perform the anastomosis. Conversely, to make an anastomosis with the inferior mesenteric vein is usually not difficult. There is a risk of plication but you can avoid plication, and you can enlarge the anastomosis with a very small patch. It's not very difficult to do, and your aim is not to have a definitive patency. The aim is to have a patency for several days. And if there is a progressive thrombosis of your anastomosis, it's not a problem because the collaterals can develop, and the gastric congestion and splenic congestion can be avoided if the thrombosis appears progressively. Regarding superior mesenteric artery clamping, I would say that if you plan to clamp the venous system for more than 40 minutes, it can be useful. End-to-end anastomosis needs at the most 20 minutes to be done. A long lateral patch, peritoneal patch, can be sutured within 30 minutes. So it's very exceptionally needed to clamp the superior mesenteric artery.
Okay. Thank you, Professor. I have another question, but I think Paulo, Paulo, please.
Okay. Once more, in my name and the name of the Brazilian HPB College, I'd like to thanks to opportunity to watch this nice talking, Professor. Very nice. It's a full extension of the subject, and I'd like to do 2 questions. What about frozen section of the remaining pancreas? Do you do usually or not? And few words about triangle operation. Want to do this an extension of the duodenal pancreatectomy. Thank you very much, Professor. It's amazing.
Could you repeat your second question, please?
Few words about triangle operation and extension of the duodenal pancreatectomy. When to do it?
Okay. Frozen section, we perform routinely frozen section, at least in two diseases, PDAC and IPMN. PDAC, because although there is no a full consistency of data regarding the positivity of the pancreatic margin, the prognostic significance of positivity of pancreatic margin. Some studies describe that even if you extend the pancreatectomy because the first pancreatic section was positive, the prognosis is not improved. Some papers from USA showed this result. Some other papers are not in accordance with this finding and demonstrated that to extend pancreatectomy, if the frozen section is positive, is useful for the patient and improve survival. I also think that frozen section of the pancreatic margin is not so very easy for pathologists. So you have to train and to train. So the more often you perform frozen section, the more you are accurate. So personally, I perform always frozen section of the pancreatic margin. For your IPMN also, I think that if you resect pancreatic adenocarcinoma complicating IPMN, you have to be sure that there is no high-grade dysplasia on the main pancreatic duct or cancer cells if you are close to the infiltrating part of the tumor also. So frozen section for every patient with PDAC and IPMN. For a neuroendocrine tumor, for instance, it's not necessary. For cholangiocarcinoma, it's not necessary on the pancreas. It's necessary on the bile duct. Triangle operation, we have not great experience with this operation. We perform, I would say, only when we perform resection for borderline or locally advanced carcinoma located in the middle of the pancreas. A tumor located of the middle of the pancreas is very difficult to resect completely with R0 margin, and usually you skeletonize the SMA, the hepatic artery, the origin of the splenic artery. You resect the venous confluence. You go very posteriorly to the origin of the SMA and celiac trunk, and you perform a triangle operation. But we did not perform routinely triangle operation for every PDAC. My personal opinion is that triangle operation induce a lot of functional disorders, particularly diarrhea, also increase the risk of lymphatic chylus complication. And I think it's probably excessive in the majority of patients we operate for PDAC.
One more last question, Professor. Or what the whole of the minimally invasive surgery in pancreatic duodenectomy? When to do it?
But minimally invasive surgery in pancreatic duodenectomy, to my opinion, I am an old-fashioned open surgeon. When I indicate a laparoscopic approach, I speak to my colleague, Dr. Doc Mack, or some other assistants very involved in laparoscopic approach. I would say that the laparoscopic approach is mainly indicated in young patients with tumor not borderline and not locally advanced, and with dilated duct. Preferentially also in non-obese patients. If all these conditions are present, the postoperative course will be favorable regarding the healing of the different anastomosis, and the benefit of laparoscopy will be observed in terms of length of stay, cosmetic results, rehabilitations, and so on. For patients with more advanced disease, with small ducts, with nodal edge, with high risk of pancreatic fistula, I'm not very sure that pancreatic duodenectomy is beneficial. That's my opinion.
Thank you, Professor.
Okay. Professor, one more question, please. In resectable distal lesions, left lesions, in your opinion, for a decision-making process, when do you perform upfront surgery and when you indicate a new adjuvant treatment? What's the role of tumor markers? When do you perform resection in resectable distal lesions?
It's not a very easy question. I think that indication of upfront surgery is sustained in every patient with PDAC by a high probability of performing R0 resection. So patient with ICR99 level, patient with posterior infiltration of the prerenal fascia, patient with infiltration of suprarenal gland, or infiltration of adjacent organ, or infiltration of vessels, splenic vessels, very close to the origin of the splenic vessel, so close to the origin of a splenic artery and close to the confluence of splenic vein with mesenteric vein. I think that this, or also infiltration of the duodenojejunal angle, but could be difficult to diagnose, are good candidates for neoadjuvant treatment.
Okay, okay, Professor. Thank you very much.
So I would like to thank you again, Professor Sauvanet. It was at last we had the opportunity to listen to you and to have your presentation. I'm very happy for so. And now I think we're going to continue on Professor Docmer's presentation. And I'd like to thank you once again for your time, your availability, and to be with us on a sunny day in Paris, talking about such a, I think, marvelous subject. Thank you very much indeed. And I hope next January I'm going to be in Paris to meet you personally, if you give me the opportunity.
Thank you so much for this kind comment. I was very happy to make this lecture. I'm very sorry of the length, but it's not very simple to focus more because this operation carries a lot of questioning and difficulties.
It's true. Thank you very much, sir. Now I'd like to invite Professor Safi Dokmak for his presentation, who is going to be about just a moment, please, about minimally approach to pancreatic resections. And for the discussion of his presentation, as I presented before, it's going to be Dr. Andreella Petrucciello. And I invite also the Marciano and Paulo, if they can stay with us for this discussion that's going to be held. Thank you very much.
So I will my screen. You can see my slide?
Yes, we can.
Okay. You have my slides, okay?
Yes, perfect.
Okay. Thank you again for the invitation. It is a great pleasure for me to be with you today. And my talk, it will be on laparoscopic pancreatoduodenectomy. And I will focus mainly on our experience because as you will see, it is not difficult to start with this program. And as you mentioned before, that is even by this approach, there are few centers who perform this kind of operation. As you know, I work in Beaujon Hospital, and we do only HPB surgery. We do nearly between nearly 300 pancreatic resection. 40 to 50% are done by the laparoscopic approach. Of course, I talk about not only for PD, of course, for distal, for central, and for enucleation. We do about 250 and 300 liver resection and about 100 liver transplantation. We do only HPB surgery. We start our experience in laparoscopic pancreatic surgery in 2008, 2007. And as you will see, this activity progress every year. In this diagram, we see that actually we do nearly about 100 laparoscopic pancreatic resection per year. This is until 2019, but in 2020, we have performed 84 cases. It was the COVID area. And the last year, we have performed 102 laparoscopic pancreatic resection. Our topic today, it will be focused more on laparoscopic pancreatoduodenectomy. Between 2008 and 2021, we have performed 855 laparoscopic pancreatic resection, 240 laparoscopic pancreatoduodenectomy, and the other procedure. And of course, the other procedure, we have the distal. We have more than about 100 central pancreatectomy. We have enucleation, and we have a few cases of total pancreatectomy. As you know, laparoscopic pancreatoduodenectomy, it is a demanding complex surgical procedure. There is not only the resection, because if we compare to the major liver surgery, if you do major right hepatectomy, after the resection, the intervention is already finished. It is not the case with pancreatoduodenectomy, because you have the dissection, and after that we have 3 anastomosis at least, and sometimes if you do some venous resection, you have 4 anastomosis. We have a dissection along the vessels. You have the mesenteric portal vein, you have the superior mesenteric artery, the hepatic artery. So the dissection, it is much more difficult. For that reason, it is a very difficult procedure to do by the minimally invasive approach. I think, as I mentioned, it is complex surgical procedure. It is difficult, at least in the beginning, to compare between the laparoscopic and the open approach. We know that the open approach, at least it is standardized since 1945. The risk of mortality is between 3 to 5%, and it is associated with high major morbidity between 40 to 50%. The laparoscopic approach, it is performed in the last decade, since 10 years ago. And we know that there is many questions about the feasibility, about the result, the benefit of this approach, and of course, in the safe implementation. Regarding our experience, we start laparoscopic pancreatic surgery in 2008, and the first laparoscopic Whipple was in 2011. Personally, in my mind, in 2010, in my mind, it was for me, it was not possible to perform this operation by the laparoscopic approach. We start on April 2011, and we have done the first evaluation in 2015, and we published the first paper in American Journal of the American College of Surgery, and we show it in this paper that we have increased morbidity compared to the open approach. What we have done, we move in this case to patient selection, and at the same time we improve the surgical technique. And we have done another evaluation 1-2 years ago, and I will give you later at the end the recent evolution of the result and this technique. This is our first experience between 2011 and 2014. We have performed 46 laparoscopic PD, and we compare to 46 open. And as you will see, when we start this operation, we do it mainly in patient with lower body mass index. And we can see that the difference was significant. And of course, when we started, we do it in patient with a small lesion, no vascular invasion, with higher rate of soft pancreas. So theoretically, when we start the experience, we started to do it in patient at high risk of pancreatic fistula. We know that the resection, it is not complicated, but of course the risk of fistula and complication was higher. And this is the result of our first experience. If we look between the laparoscopic and the open approach, we have higher morbidity, higher grade C pancreatic fistula, higher rate of bleeding, higher rate of reintervention, no difference on the readmission, no difference on the hospital stay. So for this first experience, the laparoscopic approach was inferior to the open approach. And the main predictive factor for severe pancreatic fistula was hard pancreas. And when we compare between patients who had resection for pancreatic adenocarcinoma, because we know that these patients are at low risk of pancreatic fistula, we have 15 patients in the laparoscopic approach, 14 in the open approach. We see that there was no, the outcome was similar in this population. This is mean that if we perform, at least in our experience, this kind of operation in patient at a lower risk of pancreatic fistula, the outcome in our experience was similar to the open approach. So since our first experience, we start to select the patient. As Professor Souvenet mentioned, we start to do it mainly in patients at lower risk of pancreatic fistula, mainly patient with dilated main pancreatic duct, no fat infiltration. In female, why? Because in female, we know that the female are at lower risk of severe pancreatic fistula compared to male. There is no many visceral infiltration, visceral obesity, and young, because we have a young patient with solid pseudopapillary tumor or IPMN. And at the same time, we ameliorate the surgical technique. And since 2019, we adopted, we have the laparoscopic 3 vision. And for us, really was a great advantage, because with 3D vision, the resection was much more higher, and especially for reconstruction, it was very useful for us in order to implement this technique. What are the relative contraindication? There is no absolute contraindication, because as you will see, we can do always the laparoscopic approach. Major vascular invasion, pancreatitis, we should be careful for patients with pancreatitis. Of course, chronic pancreatitis become much more and more less indication for surgery. But if you operate on some patient who had previous ERCP with an episode for pancreatitis, you should be careful. because the dissection could be very difficult, and we know that even in the open approach it can be difficult than a patient with we have vascular invasion. Visceral obesity, it is mainly visceral obesity in man who had visceral obesity with at high risk of pancreatic fistula. Of course, we should not start with kind of patient. And as we see with Professor Souvanet, 10% of patients had medial arcade ligament, and in 5% of patients, this medial arcade ligament can be symptomatic or with significant stenosis. If we have it, of course, you can do the laparoscopic Whipple and you can cut the arcade ligament in the same day. But because we know that it is very difficult, and you know that the section of medial arcade ligament can be very complicated even by the open approach. So for us, it is a relative contraindication to the laparoscopic approach. Regarding the surgical technique, we use really the installation is very standardized. We have 6 port sites, 3 of 12 millimeter, 3 of 5 millimeter. Is much more better to have 2 assistants. The surgeon is between the legs. Personally, I never cross the hand with the assistant, never, because I am in between the legs. So I have these 2 port sites. We have 1 assistant on the right side to have the camera and another instrument, and 2 instruments for the assistant. Only when you are going to mobilize the traits ligament, we put the camera on the left side. Otherwise, we keep it on the right, and really we have a very good view on the pancreatic head, and especially when we are going to dissect the retroportal lamina tissue. So I will see you a sample case of laparoscopic pancreatic duodenectomy for IPMN. So this patient had invasive IPMN, double duct dilatation. It is very good indication for surgery. It is not a metastasis. It is a benign nodule on the liver. We start bisection of the gastrocolic ligament, pull down of the right colonic angle, gallbladder resection. Then we start to do the Kocher maneuver. Sometimes we control the right gastropublic vein before. We can see the vena cava. I have to mention that with the laparoscopic approach, we don't have the same vision like in the open approach. And I personally don't do like the open approach. As you will see, rapidly I will cut the bile duct. Cutting the bile duct, it rapidly can facilitate the hepatic pedicle dissection. We take the bile for bile culture. And after cutting the bile duct, we continue the lymphadenectomy on the right side of the hepatic pedicle. We can see the portal vein. I start to do the lymphadenectomy in the hepatic pedicle, and rapidly I will cut the stomach, because as you will see, hepatic pedicle lymphadenectomy become much more easy after. We cut by stapler. In some cases, we can do duodenal preservation of the pylorus, but it was not in this case. After cutting the stomach, as you will see, the lymphadenectomy of the hepatic pedicle become much more easy. Then we cut the pancreas at the pancreatic neck. In this case, we have a very good indication for the laparoscopic approach, because it is at very low risk of pancreatic fistula. We do frozen section because it was IPMN, and the frozen section was negative. And after cutting the pancreas, the lymphadenectomy on the hepatic pedicle become much more easy. We control the right gastric pedicle, the gastroduodenal artery. Is much more easy to cut the gastroduodenal artery after cutting the pancreas. And then, as you will see, the lymphadenectomy of the hepatic pedicle become much more easy. We put some, we tape the vessels, we tape the portal vein, we tape the hepatic artery, and then, as you will see, the lymphadenectomy become much more easy. And really, we do it, of course, in selected patient, like and with the open approach, and even better in some cases. Then we will cut the first jejunal loop. We put the optic on the left side. We mobilize the Treitz ligament. We already see the pancreas, the ankles of the pancreas. Then we move the specimen, the small bowel, to the right side. It is very important to remove completely the specimen on to the left side. Like that, you have really free surgical field, and we can do the retroportal laminar tissue. As I will see, I use many metallic clips and ligation because we know that we have a risk of bleeding. Then we move the specimen to the right side, the pancreatico-duodenal veins, ligation and diversion. And then we will complete the lymphadenectomy that already started on the hepatic artery. This is the superior mesenteric artery. And of course, we know in this indication was invasive IPMN, low-grade invasive. There is no need to do very extensive lymphadenectomy. You can see the hepatic artery, the superior mesenteric artery, and we are on the right side of the celiac trunk and the superior mesenteric artery. We remove the specimen. Of course, we look for the bleeding. And really now what we changed, actually, we spend a time between the resection and reconstruction in order to improve the surgical technique. We add another stitches on the gastroduodenal artery. We check for hemostasis. We mobilize the pancreatic remnant, and we put some ligation because we know that we have at least 2 arterial collateral, one from the superior mesenteric artery, one from the splenic artery. When possible, we do some omontoplasty. More and more, we do omontoplasty in order to cover the vessels, in order to decrease the risk of bleeding and of collection. We fix along the pancreatic neck remnant. We try to cover the stump of the gastroduodenal artery. And I think it is very useful if we can do it, because in some cases the great omentum is not very suitable. We pass on the transmesocolic approach because some patients do it in the retromesenteric approach, and I am not very favorable for this approach. Since 1.5 years in patient at very low risk of fistula, I do 2 continuous 1-layer anastomosis with braided sutures with Velox. Really, it is we do not analyze specifically our anastomosis with this technique, but really the results are very good. Especially in this case, we know that we are at very low risk of pancreatic fistula. We do anterior, posterior layer and anterior layer. Otherwise, in patient at very high of pancreatic fistula, we try to put an external drain, like in open surgery. So after doing the pancreatic anastomosis, we move to the biliary one, and I do terminolateral with anterepted sutures. I use Vicryl 40. And if the bile duct is really very small, we can use PDS or Prolene PDS. But of course, in laparoscopic surgery, I try to avoid monofilament because it is not always very easy to handle with the laparoscopic approach. We use anterepted suture. Of course, we can use the braided. Some surgeons use the braided sutures, but personally, I never use it for this anastomosis. After achieving the biliary anastomosis, we do peritonization because we know, and with the laparoscopic approach, no many adhesions. So peritonization, we leave at least more between 50 and 60 centimeters between the biliary and the gastric anastomosis. We do it stapler on the posterior aspect of the stomach and the anticolic. And then we put sutures on the opening on the small bowel in the stomach. We check for the hemostasis. and we put a large multitubular drain. So this is actually our technique for sample cases. So with the amelioration of the surgical technique and the learning curve, we published recently our result in the first 130 patients, because the first publication was in the first 45 cases. We divide in the 3 periods, the first, second, and third, about 43 to 44 patients in each period. And if we look to the last period, really we have less Clavian 3-4 complications. We have much less pancreatic fistula, and we have a shorter hospital stay. Really, with the experience, we have decrease in all kind of complication, mainly on severe complication, severe pancreatic fistula, and a shorter hospital stay. Which is very important, because there's many paper in the learning curve. If we look to the operative time, this is when we start our experience. Of course, it is normal that we spend more than 6 hours. Then we stabilize our operative time. And if you look at the second period, the longer time was higher. And of course, now probably we spent a little bit less operative time, but we do it much more, we improve much more better the surgical technique. That this is mean between the resection and the reconstruction, we spent much more time in order to check for the hemostasis, to add some sutures on the gastroduodenal stump, some suture on the collateral artery of the pancreatic cut surface, to do the omontoplasty, to do very good peritonization. So we spent much more time on this period. For that reason, the operative time it about between 5 and 6 hours actually. What about the learning curve? Our results are very similar to the literature data. About 40 cases are needed in order to have acceptable operative time in order to do this operation, and another 40 cases are needed in order to decrease the complication and to do some difficult cases. Of course, if we talk about the learning curve, I start in 2011, and I think if any another surgeon, he will start today or tomorrow this operation, probably the learning curve become much more shorter, because since 10 years we have learned many on and we improve the surgical technique of this operation. So the learning curve probably will be much more shorter. This is the result of our 220 patient. So the mean age 57. We have male and female equal. We do all kind of pathology. We have IPMN, invasive IPMN. We do it in patient with adenocarcinoma, but more and more you will see we do it in patient with neoadjuvant treatment, because in our department it become very rare to operate a patient with pancreatic adenocarcinoma without neoadjuvant treatment. We have ampyloma, we have neuroendocrine tumor, very few cholangiocarcinoma. It is not a very good indication. Solid and cystic pseudopapillary tumor, it is a good indication because our young female at low risk of complications, so it is very good indication. The operative duration is 320 minutes, very few blood loss, 5% of transfusion, 4% of conversion, and in 10% of cases, 22 patients underwent a venous resection. We'll talk about later about venous resection. What about the complication? We have a 3% mortality, 26% grade B and C pancreatic fistula, 14% of bleeding. Probably with the laparoscopic approach, and if we don't have a complication, we have less delayed gastric emptying comparing to the open approach. 16% of reintervention. This is the data of all patients, but as I showed you earlier, the results are much more better in the last period. Very few patients with a drainage collection because we put systematically a drain, and the patient who have pancreatic fistula are kept in the hospital until complete healing. Very few respiratory complication. The mean hospital stay is 22 days, and as you see, and comparing to the some American cities, we have very few rate of readmission, only 4%. But with the experience in the learning curve, we extend progressively to difficult cases, and difficult cases are a patient who need venous resection, a patient who are operated after chemotherapy and radiotherapy, because if you look to the literature, there is no many data on laparoscopic approach for patient who underwent previous radiotherapy. Tumor at the head neck junction. For me, we have more and more patients at this location. This location are already by the open approach is difficult. So if we are going to do it by the laparoscopic approach, it is not so easy because we have to cut on the left. And when we cut on the left, we have the splenic vein, we have the splenic artery. And usually there is association, we need to do some venous resection. And of course, of larger tumor, there is no indication for large adenocarcinoma. It's mainly for solid and pseudopapillary tumor in young female, some very few neuroendocrine tumor. What about venous resection? It is possible to do venous resection in very selected patient, and after doing the control of the venous, like in the open approach, we can do venous resection. In our experience, we have a 22 patient, mainly for lateral resection, and we have recently we have done 2 truncular resection. And in this group, we don't have mortality, we don't have thrombosis. Especially when we do lateral resection, we do it with the laparoscopic approach, and we do it with the peritoneal patch. And in this indication, the peritoneal patch is a very good indication, because when you do it by the open approach, you can harvest a graft from any area in the abdominal cavity. But if you do it by the laparoscopic approach, you don't have many choice. It is not so easy to harvest the left renal vein or the inferior mesenteric vein. So it is a great advantage, the peritoneal patch for the laparoscopic approach. So I will show you a case, difficult case. This patient had 74 years old female patient, pancreatic adenocarcinoma, treated by chemotherapy and radiotherapy. We have an accessory right hepatic artery. As Professor Sauvanet mentioned, these patients are, we do embolization of the artery in order to have collateral circulation, and like that we can do the resection, and we resect the artery. So we can see this is the right hepatic artery. We have the embolization. If you can see, now we can see that the coil is very close to superior mesenteric artery. And as you will see with this coil, this will make the dissection much more difficult, because we will have many inflammation, especially along the right side of the mesenteric portal vein. So we have rapidly collateral circulation, so we can resect the artery without reconstruction. And this is the CT scan before. This is the superior mesenteric artery, and you can see that the coil are really very close to the superior mesenteric artery. And of course, we have many artifacts. It is difficult to see. But in this patient, we will do the resection with resection of the right hepatic artery, and we will do venous resection. So this is the resection of the right hepatic artery in the hepatic pedicle. We try to preserve the bifurcation of the artery. We cut by a stapler, 35 millimeter stapler. It is very, very useful. We already cut the bile duct. Of course, I will show you this video mainly for the artery and for venous reconstruction. And of course, if we decide to do venous resection, like in open approach, we try to do all the dissection, and we will end the resection by the vein. So this is the superior mesenteric artery, and you can see the right hepatic artery with the coil. It is enlarged, dilated. It was not so easy to dissect. It was difficult to mobilize the artery from the right side of the portal vein related to inflammation. And now you can see this is the superior mesenteric artery, and this is the right hepatic artery. And more we try to ask the radiologist to keep the coil away from to leave at least 1 centimeter, but in this case it was less than 1 centimeter. And as you will see, we will cut with the stapler, but we will cut on the coils because there is the distance is really very short, and we don't have to take any risk on the superior mesenteric artery. So we cut the artery, and as you will see, we will add some stitches, because I am not sure that it is very very secure, this kind of stapler on some coil in the artery. As you mentioned, since more than 2 years, we have the 3D vision, and really with the 3D vision become much more easy to do suturing. We put some stitches with Prolene. And as you will see, like in open approach, we cut the artery, the retroportal laminar tissue is already done. And now, as you will see, we have to do lateral resection of the vein. This is the specimen. We move the specimen to the right side. We have the splenic vein, the left gastric vein. In this patient, the same, we cut a little bit on the left, the superior mesenteric vein. And we harvest, as you see, by the laparoscopic approach. It is very easy to harvest the falciform ligament. It is done in the same exposure. There is no need to change the exposure. We avoid to take a fat width. We have some arterial collateral circulation, probably related to the embolization, because in this patient the middle hepatic artery was relatively of small size. So we clamp the splenic vein. We can clamp with this vascular tap. Is much more better than to use some vascular clamp, because vascular clamp, it is not so easy to put it, and it take some places. So I put only vascular clamp on the proximal side of the vein, on the superior mesenteric vein. You see, this is the only vascular clamp, and the other I put it with the vascular tap. We have very inflammation and adhesions with the vein. As usual, it is very difficult to know if it is related to the inflammation or to tumor. But of course, when it becomes difficult to dissect the vein from the pancreas, in this case we can do resection. In this case, we do lateral resection. And really, when we have good candidate, not complicated, easy, and if you can control the vein, we can do some lateral resection for the vein by the laparoscopic approach, like in the open approach. of course, in our experience, in this case, it can be possible to put suture, but of course we know that if we put a suture without a patch, the risk of stenosis is very high. Really, we put sample stitches in only very selected cases. So this is after unclamping of the vein. As you will see, there is no bleeding, there is no stenosis. And for this reconstruction, we use Gore-Tex stitches with Gore-Tex. Another difficult case is a young patient with a solid and pseudopapillary tumor with a very close contact with the anterior aspect of the inferior vena cava. It is very rare to have invasion, but we have this patient. And you can see in this case it's not so easy because we have to mobilize the specimen from the right and left side. This is the tumor. This is the vena cava. This is the right renal vein, the vena cava. We already cut the retroportal lamina tissue. This is the left side of the vena cava, lateral clamping of the vena cava. And of course, we know that this is a tumor. We should avoid the tumor rupture. I don't know if there is, in this case, was no invasion of the on histology of the venous wall, but of course we should avoid the rupture of the tumor. The same, we harvest a peritoneal patch, and we do lateral reconstruction of the vena cava with this peritoneal patch. We declamp, and this is the final aspect. And as I mentioned, in some patients at very high risk of pancreatic fistula, we put an external drainage of the Wirsung duct in order to decrease the risk of severe pancreatic fistula. What about resection for malignancy? We published recently our experience in patients with ampullary carcinoma, because we have many patients who had this resection by laparoscopic approach, and we compared 31 laparoscopic to 72 open cases. And if we can look for the overall survival and disease-free survival, the long-term survival was similar between the laparoscopic and the open approach. More and more, as you mentioned, we do, because initially when we started our experience, there is no many patients of good indication with adenocarcinoma to do the resection by the laparoscopic approach. But more and more, as we do neoadjuvant treatment, we have downstaging. So we have a patient with smaller size, and even if we have some venous lateral resection, we can do it by laparoscopic approach. And now we have done a, but not yet published, study, 30 patients who had laparoscopic approach. We compared to 60 patients who had the open approach. The similar morbidity and mortality, we don't have mortality in the laparoscopic approach for patients with adenocarcinoma, and there is no impact on survival. This is the curve of survival when we compare between the open and the minimally invasive approach. The curve of survival are similar. As you know, in the literature, there is many retrospective study to compare between the laparoscopic and the open approach, and there is no difference. There is no randomized study for pancreatic adenectomy, but for distal pancreatectomy, as you know, that we will soonly have the result of the diploma study for patients with left-sided pancreatic adenocarcinoma. We'll have soonly the result of the multi-European and international study. This is the same disease-free survival. It is similar between the open and the minimally invasive approach. If we, for our recent experience, this is only to give you an idea. this is mean if you are a surgeon and you have experience with the laparoscopic and open approach, I analyze only the cases, or I decided to operate on personally. In the last 2 years, 74 patients, 52 by laparoscopic approach and 22 by the open approach. This is mean if you work in a center with many pancreatic resection, and if you have experience with the laparoscopic approach, nearly 70% of cases can be done by the laparoscopic approach. Of course, we don't do by the laparoscopic approach a patient with major venous invasion or who need arterial resection or pancreatitis. But already 70%, I think it is very good percentage of patients who can be treated by the laparoscopic approach. The same, we have done another study, not yet published, but we'll soon send it for an abstract. In the last 100 cases, we don't have conversion, we don't have transfusion, we have 2 mortality. A grade C postoperative pancreatic fistula, we have really a significant decrease in grade C postoperative pancreatic fistula, less than 5%, and we have less than 10% of reintervention. So the results are much more better with the learning curve, patient selection, and the amelioration of the surgical technique. So you know that in 2018, it was the first international guidelines on minimally invasive laparoscopic surgery. It was held in Miami in March. And regarding pancreatic adenectomy, it was recommended to do it only in high volume center, and to do at least 20 cases per year per center, because otherwise in low volume center, we know that there is increase in morbidity and mortality. So the recommendation only high volume center and at least 20 cases minimally invasive per year per center. Pancreatic adenectomy, if we look about in HPB surgery, it is the procedure with the highest number of randomized studies. There is 4 randomized studies. The first one is from Spain, but no many patients, 32 and 29, and the study was positive for laparoscopy regarding major morbidity, and the hospital stay was shorter. The second one, it was from India, 32 and 32. The study was positive for the laparoscopic approach and mainly on the hospital stay. The third one was from the Netherlands, 50 patients versus 49. And this study was negative for the laparoscopic approach with high mortality. But I have to mention that this study from Netherlands is very important for two aspects. I think the first one, the experience was with this randomized study, and we know that in some surgeons you don't have enough experience in pancreatic surgery and less with the laparoscopic approach. But the message from this study that if we start this operation with no enough experience in the low volume center, we are at risk of high mortality. So we should be very careful. And since this study, the laparoscopic approach was abandoned in Netherlands, and now they do it with the robot. And the fourth one is the largest one from China, 328 cases, laparoscopic and open approach. And this study was positive for the laparoscopic approach, and only with 1 day difference, but it was shorter in the laparoscopic approach. To conclude, laparoscopic pancreatic adenectomy should be preserved to high volume pancreatic center. The results are improved with the experience in the patient selection. 3 or 4 controlled randomized studies are in favor of the laparoscopic approach compared to the open approach. And in the end of September this month, we will go to Brescia, because in Brescia we'll have the first internationally evaluated European second meeting on the minimally invasive surgery. And of course, we'll have something on the minimally invasive pancreatic adenectomy, because since this meeting, the first meeting, we have at least 3 another randomized study on the subject. Thank you for your attention.
Thank you very much. Thank you very much indeed. It was really very complementary to the Professor Sauvanet class. So I think that we have achieved all the aims that we had previously thought. Thank you very much indeed, especially for the numbers and the results and the level that you have reached. So now I'm going to open the questions to Andrea Petrucciello and Marciano Anguinoni. Thank you.
Thank you.
Professor Dokmak, if you take a glance your information and your speaking, I think that I can speak for others. We are already converted surgeons to minimal invasive approach, because of course we see these beautiful operations perfectly done with fast surgical time and great results. And we do already routinely some other HPB operation, right hepatectomy and pancreatic left resection. So we see without some filter, there is the risk of becoming over enthusiastic about this technique. But the question that I have, they are, I think, the more of the same. The general question done in this field. Of course, the aspect of the safety and mostly oncological safety come first. And but we had this in colon cancer, in gastric cancer. At the beginning, there was a lot of skepticism about the oncological safety in other field of abdominal operation, not only in digestive surgery, but in urological oncology and endocrine surgery, adrenal gland, and so on. But the studies into the years showed that this operation, they are not worse done by minimal invasive approach. So this is the first point. I think that we have enough data in pancreatic resection to show that at least they are not worse. My worry, not my worry, but my curiosity is about the reproducibility and training for this operation. And how could you and your team help us to develop this? Because the Brazilian Medical Society is not so organized as the French one, so we don't have this kind of centralization. It is impossible for us to develop a learning curve of 100 cases here in a laparoscopic pancreatic resection. So first question, I've introduced the topic, but the first question, how do you teach your trainees to do this operation? What is your protocol of training? There are other surgeons that you have trained that already have accomplished the learning curve, and they're doing well, first of all. And second one, for example, our reality, we have already at our disposal the robotic platform. We do the endopancreatectomy in open approach. Do we go for an extensive training in laparoscopic pancreatoduodenectomy, or do we go directly for robotic approach, maybe hoping for a shorter learning curve? So I think this is my first question. There are many. I don't know if we will have time for this, but I think that this is what most people ask. Do we go for laparoscopy? Do we go direct for robotic? How do you train for this?
Thank you for your question. Regarding training, yes, in our department, of course, we have some fellows, some resident. The watch, because we have many cases, and really we have some. The first important thing, I think, is the facilitation of the surgical technique. I think what we try to do, I think if we should not necessarily do it like in the open approach. I think for minimally invasive, we should make it much more easy. As you will see in the video, I cut rapidly the bile duct, I cut the stomach. In this kind of amelioration of the surgical technique, really what's very useful in order to implement and facilitate the surgical technique, at least in our department. Yes, to give you an example, we have in our department a fellow, 2 years of fellowship, young surgeon. They see a few cases, and he was able to do it alone, and even to start to do the anastomosis. I think the facilitation of the surgical technique and to look to go to a department we can do it frequently. I think it is very important in order to diffuse the surgical technique. For the robot, personally, I don't have experience, but we will start, I hope, the next year to have the robot. I think with the robot, we will have more higher of surgeon who can do minimally invasive pancreatic duodenectomy, but I think only for easy cases. I am not sure that we will have very complicated cases with the robot. Why? Because as you know that for laparoscopic, and when I do it for difficult cases, I have two assistants. Because sometimes we have to retract the vein, the liver, the small bowel to aspirate. I think with the robot, probably, I don't know if you have some experience or no, we don't have these facilities in order to have, it is difficult to have two assistants. It is difficult to have assistant. I think probably for sample cases, I think we can do it by robotic, and reconstruction is probably much more easy, but I am not sure that we can do with the robotic difficult cases. In difficult cases, a case with venous resection, a cases with some inflammation after pancreatitis, a larger tumor, I am not sure that we will be much more easy with the robot, at least in the few coming years. And I know that in the many surgeons, I know that in Netherlands or in Italy, they do the robot. When I discuss with them, they do the resection by the laparoscopic approach, the reconstruction with the robot, and even in some patients, they do small incision to do the reconstruction of the gastroesophageal anastomosis. So very complicated, and I imagine for the nurses or for the assistants is much more complicated. I think we will see on the futures.
Dr. Marciano.
Marciano want to ask another question.
You're muted, Marciano.
Okay. I'm sorry. Professor, congratulations for your presentation. I'm very happy because your presentation and presentation of Professor Savanet were recorded, were available on YouTube, and I'm very happy for that. You can see it again. Professor, we know the problem with laparoscopy in pancreatic head tumor is not related to laparoscopic procedure. But as Andrea said, there are concerns that the extensive learning curve could increase the risk of complication, even in the setting of trained surgeons working in centers performing 20, 30 or more surgeries annually. And the example we have is the Leopard 2 trial you showed us. but you showed your amazing experience with fantastic outcomes. And as Andrea said, it seems to us that it is a easy procedure, but it's not, we know. And I don't have much more to comment. Just thank your presentation, and maybe you could a little bit about your how do you select patients, and when do you decide for conversion, Professor Safi? Thank you.
Thank you for your question. Of course, I think sure it will be difficult to implement, but I am sure that more and more we have young surgeons, very experienced with the minimally invasive approach, and probably the learning curve will be much more learned with this young surgeon, with me, with another surgeon or 10 years ago. Probably, I am sure. Patient for conversion, really in our experience, we have very low rate of conversion in laparoscopic pancreatic surgery. We have 3%. And as I mentioned, in the last 100 cases, we don't have conversion. Why? Because I think we have very good selection of patient. We have very good analysis of imaging. We do many stuff with the radiologist to look for the contact with the vein, with the artery. We pay very attention patient who present pancreatitis. So I think very good analysis of the imaging, very good analysis of the surgical technique. Facilitation of the surgical technique is very important. For that reason, we have a very low rate of conversion. But of course, if you are doing to do it and you have for me, the indication for rapid conversion, if you have uncontrolled or major bleeding from the major vessel, for that reason we should clamp and you should convert. But we have only one case. I think the last patient like that, it was 7 or 8 years ago. We don't have. And for young surgeon, when we start, of course, we try at least to be, there is a senior surgeon in the available. For that, if they have in very difficult situation, they can call for a senior surgeon to help them.
Okay, thank you, Professor. João,
thank you.
No more questions. I don't know if the audience have any question.
No, I didn't have any question from the audience. Do you have any last question, Andrea?
Yes. Another topic, Dr. Dokmak, is about the indication of surgical reintervention.
Yes.
I don't know your opinion about this, but for example, in colonic surgery, one of the main advantages of laparoscopic approach is that you can take a look if you are in doubt more easily when you have a borderline situation. You have a patient that they have some fluid collection. You don't know if this is getting infected. And when you have operated on the patient by laparoscopic approach, there is no difficulty and very little morbidity in going back to the OR and approach again this patient, put a camera and take a look if you have to do some cleaning, some drainage. I know that, of course, in pancreatic cancer, pancreatic operations, the main indications for percutaneous and radiological guided approach. But in this extensive experience, have you had any situation where you use this advantage or have made a laparoscopic approach to go back again and take a look at the abdominal cavity in a quick way? I ask this because personally, I think that this is one of the greatest advantage of minimal invasive approach. You can literally open and close as many times you want to take a look. So taking the particularity of the pancreatic resection, have you ever had some situation like this?
Well, very good question. Really, for pancreatic head resection, the response, no. We have some re-intervention, but are done by the open approach. When it is very early, it can be bleeding from some port site or local bleeding, but it is very rare. But really, when there is indication for re-intervention, usually for severe complications, grade C pancreatic fistula or bleeding, and in this case, we'll go usually by the open approach. But in our department, in our hospital, for open and laparoscopic cases, we do frequently CT scan, and we go frequently for interventional radiology in order to put, even in some patients, if we have a bleeding, early bleeding, and the patient is stable, we try to do a CT scan, and even we can embolize some patient. We just some embolization and even an early bleeding if the patient is stable. And for delayed complications, more than 90% of cases we try to resolve with endoscopic or percutaneous drainage. But we do it more frequently in distal cases. After distal pancreatectomy, we have much more patients, but less than 5. We try to do by the re-intervention by the laparoscopic approach for early bleeding or for some undrained or not well-drained pancreatic fistula. Of course, we have less adhesions in the abdominal cavity, but locally, really, when we do, even if you do it by the laparoscopic approach, you can have many adhesions, and not so easy to do it always by the laparoscopic approach.
Perfect. Thank you, Professor. John.
Well, I think that I would like to thank you very much. You have both offered more than 2 hours and a half of your time, of your experience of one of the largest world centers with more than 300 pancreas cases a year. It's probably what's performed in all the state or where we live, which is 11 million state. I think that if we put together all the hospitals in this state where we live in Brazil together, we do not perform 300 cases a year probably. So I would like once again to thank you very much since the very beginning, since the first invitation that I have sent you. During your vacations, you have quickly answered back. And Professor Sovanet, thank you again. Thank you very much indeed, sir. And I hope that next January I'm going to be in Paris, and I hope to go to Beaujon and finally know you personally. And thank you very much for you too, Safi, especially for yesterday, for all your availability, saying that there's no problem about leaving at your house at midnight to go to the hospital for your presentation. And I said, no, not necessary to do so. It's not a transplantation.
I am like Professor Vanet, are very available for giving any talk or for coming to the hospital.
Yeah,
I confirm.
And thank you for the French school that I had the opportunity to have trained for 3 years. And that certainly made a lot of difference in my career. That I've been 22 years in Brazil, and certainly all that I do is because of what I have learned in France. And the way that I was treated, I would like to publicly thank you for the way that you treat people that go to France and the way that you train us. I think that Andrea Petruzzello can say the same, because he was trained in the Montpellier, and the way that he performs his TPCs is very French way. The first time I saw it. So thank you again, and I hope you have a nice weekend. Thank you, sir.
Thank you for you. Thank you
very much. And
thank you.
Congratulations for the organization of this session this afternoon, and have a nice weekend too. And we hope, Safi and we hope by our talks will be useful for the largest number of Brazilian surgeons.
Thank you, sir. So I'm going to officially close after Marciano talks. I'm going to officially close this section.
Okay, thank you. Okay, João, thank you for you. Thank you, Andrea, Paulo. Thank you very much again, Professor Safi, Savané, for your time, for your kindness of being here with us. And it was really, really amazing. So great weekend to you all.
Andrea, last word.
Yes, same words. Thank you for your time. And be sure that I have a personal relationship with France as João Nicolucci, and but France is a school that is making a lot of fellows and students all around the world. So your words are being spread worldwide. Be sure of that. And I think that those lectures, particularly of Monsieur Alain Sauvanet, made it clear that we are going in the right way. So thank you again for your time. And for me also, and for Marciano, I hope we'll see you personally in a short time, maybe. Yeah. And maybe, João, if you want to close officially, and thank you again.
Okay, so we're officially going to close these lectures. Thank again everybody that have been following us and attended this online Congress. And we hope that shortly we're going to have these authorities back with us for other conferences. Thank you again. Have a nice Saturday and a nice weekend. Thank you all.